discuss part 2 of the implants topic, plates and tension band wire. Right, so we discussed about screws in our part 1. So today we're going to move on to the plates. Right, coming to the introduction of plates. Plates is a load sharing device. Right, so nails are load bearing device. Load sharing device is that it will only last for as long as the fracture tries to unite. After a certain period of cycles, this will fail. So a load sharing device like a plate will fail after a certain period of time. The next concept that we should understand is the working length concept. Well, the more the working distance or the working length, the stress distribution is more and the fracture failure is less common. The lesser the working distance, the stress distribution is less and therefore the plate may fail more easily. And this is why working distance is very, very important. Next, coming to the bending rigidity. Bending rigidity is directly proportional to the cube root of the thickness of the plate. The more thicker the plate, the more rigid the plate is. So bending rigidity is directly proportional to cube root of the thickness of the cube of the thickness of the plate. This is very important. Coming to the concept of stability, we discussed this in the previous screws chapter. Right, the stability can be of two types. One is absolute stability and the second one is relative stability. In absolute stability, the strain is less than 2% and the bone heals by primary intention. You have got compression, good compression in the fixation, for example, like a dynamic compression plate. They heal by primary intention without callus formation. Relative stability is where the strain is between 2 to 10%. They heal by secondary intention, for example, like external fixator or bridge plating, and they heal with callus. The third group is when there is no stability at all. When there is no stability, that is the strain is more than 10%. There is no callus formation, rather there is fibrous tissue formation and there is no healing, no signs of, and this fracture will probably proceed to become non-union. Fracture can be classified based on the form or function. So based on the type of the plate or appearance of the plate, there are various types, including dynamic compression plate, which is the most common plate which is used. Then we have in the locking fashion, when you use a screw in the locking fashion, it's called locking compression or locking plates. Then you have the low contact DCP, where the contact of the bottom of the plate is minimized or decreased as compared to the standard DCP. So when you decrease the contact between the plate and the periosteum, the blood supply to the bone, the disruption of the blood supply to the bone is much lesser, and therefore theoretically at least there is increased chance of union of the fracture. Based on the plate size, you can classify the plates as, for example, as 3.5 millimeter plate or a 4.5 millimeter plate, and you have also the semi-tubular plate or 1/3 semi-tubular plate, and such types of plates based on the plate size can also be classified and described. Then you have pure locking plates, which are similar to the locking compression plate, but these are pure locking holes are present, so these are called as locking plates. Then you have site specific plates, like for example the volar locking plate or the philos for the proximal humerus, the distal tibia, proximal tibia, and so on and so forth. So you have site specific plates. Then you have shaped plates like the T plate, clover leaf plate, and so on and so forth. So you can classify the plates based on their form, and they were classified into various forms like DCP, locking compression plates, LCDP, DCP, or low contact dynamic compression plate, locking plates based on the size of the plate, site specific plates, and different shaped plates are present. They can be further classified into the function that they perform. Right? We most commonly use the dynamic compression plate in the compression fashion, so these are called as in the compression plating. Neutralization plate, when you use a plate to neutralize or to prevent the shearing or torsional forces on a lag screw that you have applied. Here you apply the screws in the neutral position, or positional screws are applied without any compression exerted by the plate. These are called as neutralization plates. Then you have what is called as a buttress plate, just to buttress the fragments in the metadiaphyseal region. For example, the Ellis plate of the distal radius, proximal tibial plate, or the distal fibula plate. These are some examples of buttress plate. Distal fibula plate are some examples of the buttress or the function of the plate as a buttress plate. Then you have the bridging plate, which is used to bridge comminuted fracture, where you do not want to disturb the fracture hematoma. This is called as a bridging plate. And is commonly used in such situations like tibia, humerus, and this is basically called as an internal external fixator, internal external fixator. It's called an internal external fixator. Now coming to the first of these things that we use, the DCP plate, which is used in a compression fashion. The DCP plate is made of an oval hole, right? When you make a oval hole and when you put or drill the hole in the center, it is called positional or neutral screw. Positional or neutral screw. This is the first screw that is applied on either, so you can choose either one side of the fracture and apply the screw in neutral position. The second screw is applied in the compression fashion, that is in the eccentric position. The second screw is applied in the eccentric position or in the opposite side of the fracture, and when the screw is tightened, the screw slides down. The screw slides down the sloping area, and when it presses again the plate against the bone is moved or pulled towards the fracture site, and there is compression. You can expect about 1 to 2 millimeters of compression, 1 to 2 millimeters of compression when you use this type of an eccentric screw. So the rest of the screws can be applied in neutral position. And this is called as application of the DCP plate or dynamic compression plate in a compression fashion. Next, coming to the neutralization plate, the same DCP plate can be applied without using the eccentric portion of the screw hole, and this is called as a neutralization plate. So, for example, when you have a fracture which is oblique in nature, and you have applied a lag screw to fix the fracture, this is still subject to some shear or torsional forces. Rotation forces are still present, and the lag screw can fail. To support and give additional support to the lag screw, you can use the neutralization plate, where these screws are placed in the neutral or central position. And this will not cause any compression or distraction of the fracture. So when you use this kind of the DCP in this fashion, this is called as a neutralization plate or positional plate. Other plates which function like this include a semi-tubular plate, and you can also use the 3.5 and 4.5 DCP plates in this fashion. Next, coming to the bridging plate, where you have a fracture. For example, this may be a humerus fracture where it is severely comminuted and getting compression may be difficult. You bridge this area, bypass this area without disturbing the fracture hematoma, and apply screws not in compression fashion, just in positional fashion. And this is positional or neutral fashion, and this is called as a bridge plate. This is also called as an internal external fixator. So here the fracture heals with callus formation because there is only relative stability. The strain is about 2 to 10%. Right? In lag screws or in DCP, the healing occurs via primary intention. The strain is less than 2%, and there is absolute stability, and there is no callus formation. So this is bridge plate, or the principles are similar to the external fixator application. X-fix application. Next, coming to the fixed angle plate, these were more commonly used in previous decades and years. For example, you have the DCS, dynamic compression screw, or the angle blade plate, which was used for metaphyseal fractures or metaphyseal diaphyseal fractures, where the bone is very osteoporotic. The metaphysis is very osteoporotic, and therefore you use this kind of a plate which holds on to the metaphysis strongly, prevents pull out of the plate from the metaphysis. So basically, for example, in a DCS or angle blade plate for the distal femur, the angle blade plate is inserted into the distal femur, into the metaphyseal region, and the rest of the screws are cortical screws, and this gives a very strong construct and prevents the pull out of the plate from the metaphyseal region. So this is called as a fixed angle plate. This is still used. DCS and angle blade plate are still used in some osteotomies for deformity correction even now. The most common fixed angle type of plate which is used now is the dynamic hip screw or the DHS plate, which functions very similar to the fixed angle plate pattern. Next, coming to the locking plate, where here in these lock screws, all of us know that the lock screws have threads in them and they lock onto the plate. So therefore, when you have a locking plate which is in use, the screws fail. When the fracture does not unite, the screws do not fail independently, but the screws fail along with the plate. So the screws come off with the plate. Whereas in non-locked plates or DCP kind of fixation, the screws will fail one by one. Rather, here in the locked plates, the plate comes off with the screws attached to them, and this is called as a locked plate mechanism or the locked plate technique of fixing of fractures. This is very commonly used it is used in the metadiaphyseal region. Like, for example, the distal radius, distal tibia, proximal humerus. It is also used in osteoporotic fractures. In older age patients, it is used in osteoporotic fracture in the humerus and the tibia, femur, etc. So these are the indications for lock plate. Metadiaphyseal fractures like the distal femur, proximal tibia, distal radius, proximal humerus. These are the commonest indications of the use of a locked plate. Next, coming to an important concept to finish off this part 2 of implants is the TBW, or tension band wiring. Tension band wiring technique. This most commonly which locations are it is used? It is used in the following locations. One, in the olecranon. It is used in olecranon. 2 is the lateral clavicle. 3, patella. 4, medial malleolus. These are the most common location which this tension band wiring technique is used. It can be used in other areas as well. Here, the fracture where the tensile force happens and is pulling the fracture apart, this is used and converted into a compression force. So tensile force is converted to a compression force, and this is the basic principle or premise of a tension band wiring. So if you have a patella fracture, the quadriceps tend to pull the fracture proximally, and the patella tendon pulls the fracture distally. First, K-wires are applied across the fracture site to approximate and make the fracture align correctly. Then tension band wire is used around the quadriceps tendon and the patella tendon. This will cause compression whenever there is tensile force, that is when the patient is trying to extend the leg. Quadriceps will try to pull this, but that tensile force is converted into compression force because of this type of a construct. This is very useful in case of olecranon fractures, lateral clavicle fractures, olecranon fracture, because the triceps tends to pull the fragment more proximally, and that is converted to compression force, and patient can be mobilized at an earlier date, and because of this compression, the fracture may also heal by primary intention fracture healing can occur. It is one of the most common technique used in fixing of patella fracture, and it is also used in the medial malleolus, where the deltoid ligament tends to pull on the fragment, and you can put K-wires, and when you do wiring with an SS wire of the appropriate size, stainless steel wire of appropriate size, it converts the tensile force into a compression force. So this is the basic principle of tension band wiring. One more thing that you must remember is the fulcrum, the function of a fulcrum, right? Because of the fulcrum here, that is a trochlea in the femur acts like a fulcrum. These forces are further amplified, and this kind of a technique further helps in the healing of the fracture. So this is the technique of principle of tension band wiring anywhere in the body. I hope this talk was informative and it helps you in your exam. Thank you very much.